to speak about endoscopic enucleation of the prostate and continence and how to counsel. Incontinence is one of the challenges of after endoscopic enucleation of the prostate. This comprehensive analysis from USA assessing incidence of incontinence after BPH procedure retrospectively for 10 years, and the number of patients was huge, 270,000, and outcome after 1 year. As we see here, HOLIB is associated with the highest incidence for stress urinary incontinence, and the incidence is nearly double of TUR prostate. So how to overcome these challenges? We have to take action pre-operative, intraoperative, and post-operative. Pre-operative, pelvic floor muscle training, and maybe early intervention. This study is about pre-operative pelvic floor muscle training for early continence after HOLIB. It's a randomized controlled trial including 70 patients, 35 in each arm. At 3 months, urinary incontinence decreased in group A by 3% versus in group B by 26%. We have to ask ourselves, do we operate BPH too late? This study, the influence of the medical treatment of LUTS on BPH, do we operate too late? The medical treatment resulted in change in patient demographics. The patient become older, more comorbidities, and larger prostate. The symptomatic relief may mask the gradual increase of PVR and the concurrent detrusor function deterioration. So all of these highlighted items increase the risk of incontinence. So we have to ask ourselves again, do we operate BPH too late or not? The most important part of this lecture is the intraoperative actions that may decrease the risk of urinary incontinence. And when it comes to intraoperative, the most important type is the stress urinary incontinence. It's related to surgeon experience, technique, and maybe Botox injection have a role. This study was in our center to assess the learning curve of HOLIB. It included 3 surgeons, and it divided according to the number of the procedure. The first 20 procedure, and then the second 20 procedure, and the subsequent procedures. And according to this, 313 patients was included in this study for HOLIB to assess the outcome and the difference between the first cases for new learning surgeon and the second 20 cases and the subsequent cases. And the stress urinary incontinence early stress urinary incontinence showed significant improvement between the first 20 cases and the following cases. As we see here, the difference is mainly in the early incontinence in the first months, and it decreased the difference between the 2 arms, between the first 20 case and second 20 case. Between this arm in the 4 months is decreased, and it become insignificant after 1 year. So we can summarize with more experience, we can get earlier continence. So the percent here, after 1 month, the stress urinary incontinence in first 20 case was 18%, and it decreased to 8.8% in the second 20 case. Regarding to technique, we have to follow the rules of Delphi consensus, which are early apical release, preserving apical mucosa, and gently disrupting lateral loop at their apical region, and finally avoiding excessive energy delivery near the apical mucosa. We can follow these rules by these techniques: veal sparing HOLIB, in-block HOLIB, and early inverted V-shaped apical mucosal incision. All of them are following the rules of Delphi consensus. This study is a randomized controlled trial was done in our center to assess the continence between veal sparing versus standard HOLIB. And each arm, there was about 90 patients. As we said yesterday and today in our live surgery, you have to follow the mnemonics of 8 plus ABCD, and this, if you follow this mnemonics, you will preserve the continence as much as possible. So to compare between the stress urinary incontinence between two arms, veil sparing and conventional, the conventional stress urinary incontinence after 1 month is about 23% compared to only 9% in veil sparing technique. After 4 months, it's 16 to 3%, and finally after 1 year, it's 8 to 2.4%. In block HOLIP, in this case, we can see the classic HOLIP and in block HOLIP. And the difference is the de-epithelialized sphincter and here intact mucosa over the sphincter. So stress urinary incontinence rate decreased from conventional. It's at 1 month about 6%, and it decreased after 6 months follow-up even less than 1%. Early inverted V-shaped apical mucosal incision. It's an incision done early. It's inverted V-shaped. It's also the same concept for preserving the sphincter, the mucosa overlying the sphincter. And here there is a study which was a recent study in our center. It's a randomized control trial comparing in block HOLIP versus loop by loop HOLIP, which was done by veil technique also. The conclusion revealed that in block HOLIP reduce enucleation time, operative time, and laser energy consumption compared to loop by loop HOLIP. But when comparing safety and efficacy and early continence, the both techniques are comparable. And this study, there was about 60 patients in each arm. The impact of external sphincter grading after early apical release in HOLIP on post-operative stress urinary incontinence. The idea is that any violation of mucosal layer of the apical portion can precipitate incontinence. So we have here grade 0, there is intact mucosa. Grade 1, mild denudation. Denudation means de-epithelialization of the mucosa without any tear. Grade 2, lateral tear, and grade 3, anterior tear. So we can see the anterior part is the most concerning part. Deep lateral tear into bulbar urethra can also impact external urethral sphincter complex, but the anterior part is the most concerning part. What about Botox injection? There is a retrospective study in 82 patients, 41 in each group. Botox was injected at the time of HOLIP. Botox group had significantly less incontinence at 3 months with no difference in complication rate. And usually it was urge urinary incontinence. The post-operative action, or usually the treatment, when to start medical treatment, when to start surgical treatment, and what to do at the early post-operative. Early post-operative, you have to modify the fluid, modify lifestyle by decreasing caffeine, alcohol, evening fluid, and give stool softener and avoid constipation, pelvic floor muscle training. For urge urinary incontinence, you can start with bladder training and timed voiding, and you have to make some insurance for the patient that with patient education, most recover within 3 months and more than 90% by 6 to 12 months. Then after that, if there is no response till the 2nd or 4 weeks, you have to ensure there is no UTI and no high BVR or retention. Then you can start with your medication, either anticholinergic, beta-3 agonist, or even Botox injection. Surgical intervention after failure of conservative and medical treatment for more than 6 to 12 months. We have some options like male sling for moderate and artificial urinary sphincter for severe cases, and there is, with a lot of limitation, bulking agent in a male. So the types of incontinence after enucleation may be stress urinary incontinence, urge urinary incontinence, or mixed, but the most important type you have to focus on as a surgeon during patient follow-up is the stress urinary incontinence, because this one is, there is a lot of surgical related factor and you can avoid them in the next procedures. What's the role of MRI in predicting the risk of developing urinary incontinence post-enucleation of the prostate? Here the study, there is a relationship between prostate size and urinary incontinence, a prospective study on 1,675 patients assessing the HOLIP outcome according to the prostate size. Regarding stress urinary incontinence, group A, which show the smaller size in three groups, group A, group B, group C. Group A is the smaller size, showed significant less incidence than other groups. Here the predictive factors of stress urinary incontinence after holmium laser enucleation of the prostate by MRI. It's a retrospective study including 216 cases. And in this case, in this study, there is an independent risk factor for stress urinary incontinence, which is prostatic apex and membranous urethra overlap. What is this? Here we have prostatic apex and the relation of the prostatic apex to the membranous urethra overlap. As we see here, there is the membranous urethra by red color and the apical tissue of the prostate. If there is overlap, it's usually maybe more risk for incontinence post-HOLIP more than if there is no overlap like this one. The significance of membranous urethral links for early recovery after HOLIP from urinary incontinence. This study on 78 patients depends on MRI to assess the size or the length of membranous urethra, and they divide according to the membranous urethra above 14 millimeter or less than 14 millimeter to longer and shorter. And you can see the continence at 1 month in longer membranous urethral lengths is about 80%, but in shorter it's about only 30%. But it improved after 3 months to 72%, and finally at 6 months maybe both are comparable. So the explanation is that long membranous urethra means greater quantity of muscle and more resistant to damage during HOLIP. So membranous urethral length was useful for predicting early recovery from urinary incontinence following HOLIP. Take home message: urinary incontinence is not life-threatening, but for patient it's life-changing. After HOLIP, stress urinary incontinence is usually transient. The sphincter is not permanently damaged. The new incidence of stress urinary incontinence is decreased by new techniques rather than the conventional, decreased to 5 to 9% at 1 month, and decreased after 1 year, maybe less than 1%. MRI may have a promising role in identifying patient risk for stress urinary incontinence post-operative, but need further research. Thank you.
Thank you, Dr. Ahmed, for this nice lecture. Any question from the audience? Dr. Ahmed, do you think pre-operative urodynamics is important in patient counseling?
In some cases, as the patient who already have any neuropathic elements, as usual, neuropathic elements or young age or very old age.
Also urodynamic can predict the incontinence after surgery. Especially incontinence may be due to sphincter dysfunction or may be due to detrusal dysfunction. So pre-operative urodynamic can predict a detrusal dysfunction, like small capacity and poor compliance and detrusal overactivity, which is also a predictor for urge incontinence post-operative. Yes. Thank you, doctor. Now it is the time for group A to go to the enucleation lab. Group A.